Thank you for the introduction, and thank you all for staying. I know it's the last day, so bear with us here. Do I just use this? The green button. This thing. Okay, perfect. Perfect. So I have no financial disclosures. Advances in modern medicine have allowed individuals to live longer lengths of life, especially compared to prior. In 2010, there was an article in the New England Journal of Medicine where one writer writes, since World War II, biomedical innovations, including drugs, technology, and procedures, have been the primary source of increases in longevity. With these advances, however, patients and families are requesting treatments that physicians or surgeons may not be in agreement with. Medical futility is a physician's determination that a therapy will be of no benefit to a patient and therefore should not be prescribed. Medical futility can be described in two different ways, quantitative and qualitative. Quantitative is more of a probability, so a low likelihood or less than 1% chance of achieving physiologic objectives, most oftentimes cure or survival, whereas qualitative is more of a subjective measure. Treatment would, essentially survival can be achieved, but the treatment would not meet the overall goals of the patient, such as if the patient was in a persistent vegetative state, if they had poor functional status or had poor quality of life. So how do you determine futility? In addition to using the probabilities of quantitative futility, what we should also consider is the context of the patient and the underlying illness. In addition to that, I will use an example from our own institution about our futility policy, where the attending physician has determined that the patient's condition is terminal or incurable, that the physician has also determined that the intervention in question is not going to improve patient's discomfort or symptoms, and that the intervention in question may also prolong the dying process. So what are your obligations as the surgeon? Well, we always have to respect the autonomy of the patient, but respecting the autonomy of the patient doesn't necessarily mean that we just offer surgery if they or their family request it. When a medical intervention is considered futile by the attending surgeon, there's no obligation for the attending surgeon or the surgeon to offer or provide treatment. And this is supported by both the American Medical Society and the American College of Physicians, where they say there's absolutely no obligation, or you're not required to provide treatment that you believe is going to be of no benefit to the patient. But I would strongly suggest that we all use a little bit different terminology. So the term futile or futility is a very uncomfortable word for both patients, families, and ourselves. What can happen is that futility implies uselessness or hopelessness, and it can lead to an adversarial relationship between the patient and family and the provider. The patient may feel isolated, marginalized, and they may lose trust in feeling that the surgeon has abandoned them. They may perceive a power grab by the surgeon, where they feel that the surgeon is making unilateral decisions in a paternalistic fashion. So I would suggest that we use the term either non-beneficial treatment or potentially inappropriate treatment rather than the term medical futility. This is less pejorative, it's more subjective and value-based, and can be applied to almost any treatment. It doesn't necessarily have to be life-saving or life-sustaining treatments. In an event where you are considering potential medical futility, it's always helpful to get palliative care consultation involved. Broadly speaking, palliative care is an approach that improves the quality of life for patients and families with serious life-threatening illness. So what is your role as the surgeon? Of course, it's to provide your professional opinion. Should we operate or should we not? And if we choose to operate, we fix the problem. But I would also argue that our job as the surgeon is also to provide primary palliative care skills. Now, primary palliative care skills involve basic pain and symptom management, basic management of depression and anxiety, and then also having discussions about prognosis, goals of treatment, suffering, and code status. That is not somebody else's responsibility, that's our responsibility. When should you consult a palliative care specialist? As I said before, in cases of potential medical futility or non-beneficial treatment, management of refractory pain or complex symptom management, and then also assistance with conflict resolution. So fighting within families, fighting within care teams. These are experts in communication. So if you don't have the communication tools to be able to manage some of these conflicts, it's certainly reasonable to have them be involved in the care of your patient. So we are not trained to do palliative care very well. There are very, very few training programs across the country who are actually doing palliative care skill training. So with that in mind, we are not learning how to communicate with patients. We're not learning how to consult or when it's appropriate to consult palliative care, and we don't really know the patient's trajectory. And I think that some of the main barriers to us providing palliative care or referring to palliative care is that we just, again, don't have communication training, and we have a lot of uncertainty as to what the patient's trajectory is going to be. So what do? We use NSQIP calculators, right? And so for us, this may be helpful because we can give a risk of a complication or death happening to our patients, but it helps us, I think, more than it helps the patients. These patients don't necessarily understand risk, and it doesn't matter to them until they become that 1% of chance of having a leak or something, right? Because then that's 100% to them. So I would argue, yes, this is very helpful for us trying to determine risk and mitigate some of this risk, but the only thing that really matters to patients is younger patients want prolongation of life, and older patients want to know, what is their life going to be like? What is their quality of life going to be like? So I would say that really the patient-centered outcomes from the NSQIP, which, although again helpful to us, might be that discharge to a non-home facility is the thing they care about most. And I'll say that there is literature to support some of these ideas. There was a study across seriously ill older adults where they were asked to evaluate, they were asked to weigh states of different health against disease. And so the darker colors indicate states worse than disease. And what you'll see here is that, sorry about that. More than 50% of the seriously ill older adults reported that bowel and bladder incontinence, need for mechanical ventilation, being bedridden, and being confused all the time was worse than state of death, okay? So how should you do it as the surgeon? If you're the surgeon who's seeing somebody in the emergency room with a small bowel obstruction, I think the main things that we have to think about are think about the patient's acute surgical condition in the context of their underlying illness. We have to put it all together, asking about their goals and their preferences, describing treatment options, even if it means surgery or not a surgical option. So presenting them with all the choices, and then directing treatment to achieve their goals. So goal-directed treatment, and then continued commitment to the patient. Just even if you decide you're not going to operate on the patient, not allowing them to feel that you've abandoned the patient. Or alternatively, that's a more difficult framework to think about. What you can do is, if many of you might be familiar with this, is a best case, worst case type scenario, right? So patients like stories; they understand stories, and essentially, what this is telling a story. On the right or on the left of the screen, surgery option versus a non-surgical approach. What's the best case if I undergo a surgical operation? What's the best case if I undergo no surgical option? Versus the bottom is the worst case scenario, and the circles are what's the most likely scenario. So if you like storytelling, that works too. But again, you have to think about your clinical judgment, what the evidence is, and what evidence is available that's meaningful to patients. So not just about risk of acute renal failure or UTI, they don't necessarily care about that, but they want to know where they're going to be after surgery. Are they going to go home? Are they going to be able to have cognitive and functional deficits after the operation? You want to make sure you understand the patient's goals and priorities. You don't want to give the patient and family a feeling of abandonment or isolation or having them feel marginalized when you start talking about not providing surgery. And then you don't want to feel like you're losing hope just because you can't provide or because you do not feel that it's appropriate to provide a surgical intervention. And I really would strongly say, please don't use futile to a patient and a family. It's in discussions amongst ourselves, that might be fine, but I think when you bring it to families, that can be a very uncomfortable word, and you really don't want them to get the sense that you're abandoning them or that there's some kind of adversarial relationship between you and the patient. And then what I would finally say is consider a time-limited trial. So this is something that maybe you guys do, but you haven't just explicitly said this is a time-limited trial. So it's essentially an agreement between the clinician and the patient family saying that over a defined period of time, we're going to allow certain medical therapies to continue on. And if the patient improves over this time period of time, then we'll continue on with treatment. Whereas if the patient continues to deteriorates, then we're going to stop this treatment. But what it does is it allows uncertainty both for the surgeon and for the patient family. Sometimes we don't know when somebody's going to improve with some of our treatments, and then sometimes patients' families don't really know what they want. So it takes a little bit of time to go through the process, including grieving. It also prevents unnecessary care, so time-limited trials can be beneficial from that standpoint, but there is limited utility in patients who are rapidly deteriorating, or if there's no agreement in appropriate time or what treatment options are. So again, So I'll just close by saying, why is this important? This is important from a societal standpoint. So surgery, surgeons, our time is a very limited resource. And again, I go back to this article saying that, with advances in medicine, this is also very, very expensive. So we have to think about cost containment. And of course, we all want to be providing good care to our patients. We want to give them care that's aligned with their goals and priorities. But also, I would say that this is important for us as surgeons. So this last study is a study across 2 hospitals. It's attendings, residents, surgeons, non-surgeons. 91% of these individuals said that at some point they provided futile care or care that they didn't feel like was necessarily beneficial to their patients. And of that, a third of those respondents said that because of this providing futile or potentially inappropriate care, they thought about leaving their jobs. So this impacts all of us. And so again, from a societal standpoint, from the patient standpoint, and from our standpoint, I think we really need to be thinking about when to be providing a potentially appropriate versus inappropriate care. And with that, that's all I have. Thank you.